it's to give an intervention to have a participant have delay in viral rebound when ART is stopped. And how long, what's a meaningful delay in viral rebound is really controversial for the field. Some studies use 24 weeks, an intervention that will lead to 24 weeks of ART. And some industry partners would consider 2 years because that's aligning with what long-acting antiretrovirals could potentially do, or BNAbs. For our clinical trial, we used 48 weeks or close to a year. So if any infant treated very early would achieve this 48 weeks or more off ART, we considered that a remission case for a clinical trial. Obviously, in pediatrics, it's a little different. You could have remission with low reservoir size and no immune response, as in the transplant setting. So really, it's reservoir size control, not conventional innate or adaptive immune control of HIV, as in elite controllers. And in cures, where you get to a space where you've completely eradicated all replication competent proviruses and the person experiences no viremic rebound for life. And so this is sort of just some stratification and definitions, but an evolving landscape, as I said. So I'm now going to switch to ART-free remission in children. As I said, this was the case of the Mississippi baby. Can you see my pointer?
Yes, we can.
Great. Okay. So this child presented to care in their 2 years of age, having known to be identified as being infected in the first week of life, because, of nucleic acid testing done in the first 48 hours of life, that takes about a week to get back in this country. And so she was diagnosed with infection, but what happened, she was started on a triple ART regimen, and I probably should say triple ARV regimen. It was zidovudine, lamivudine, and nevirapine. The reason I'm making a distinction between ARV and ART, at the time of this case report, there was no therapeutic dosing for nevirapine for treatment. We know how to dose it for prophylaxis in infants, which was 2 milligrams per kilogram per day. But now with the clinical trials, we've established that dose. It's about 6 milligrams per kilogram per day, twice a day. And so she received a triple ARV prophylaxis that was really unprecedented for perinatal prophylaxis. It's usually with 1 drug, or for high-risk infants, 2 drugs within a 3-dose regimen of nevirapine. Nevertheless, we decided to follow her serially monthly with viral load testing, because she had already experienced 5 months of remission. She had stopped therapy at 18 months, and she went for 27 months before experiencing viremic rebound. So we classified this as remission in her. Just try to advance my slide. And during this period of remission, what you could see is no plasma viremia off ART. So these are typical biomarkers that are used, RNA, obviously, the main one. And then she also had no HIV-specific immune responses tested during this remission period. And then she had these are her Western blot analysis, no HIV-specific humoral responses throughout the period of remission. But you could see maternal samples showing clear development of antibodies in this child. And so what we learned from this case actually was that the absence of sustained aviremia off ART for 2 or more years, having normal CD4 counts, normal levels of immune activation, being completely antibody negative, no CTLs. And actually, over that time frame, we cultured 64 million purified resting CD4 cells and didn't detect a replication competent virus. So this was really a state of viral quiescence, but persistent HIV infection. When I first presented this case, there's a lot of controversy as to whether she was infected or not, or this was prophylaxis at play. And we made the argument that these multiple closed circles representing detection of HIV viremia over the time course of treatment, and she exhibited the typical biphasic decay in plasma RNA supported HIV infection in her. But we did learn that this biomarker profile did not signify cure, so we never use the word cure now, we say remission. But what was curious is we were just starting to use droplet digital PCR, it would this is 2013, just to remind everyone. And we did detect like intermittent traces of HIV DNA that we didn't quite know how to interpret, whether it was assay variation or not. So I don't know if we can use that as a metric for there are circulating cells, and that would mean there's still HIV infected cells, with the caveat that most proviruses are defective at that level. I just need to try to get to that. And just to quickly say that her finding of remission has been modeled with the Berlin patient and the Boston patients who received stem cell transplantation, but not with CCR5 delta 32, and experienced different times of rebound viremia. To how many logs reduction would a given infant need to be able for 50% to experience remission. And Alison Hill modeled this to be about a 4 log reduction from the median of 0.5 or 1 per million resting CD4 cells. And so this is a pediatric talk, just to kind of remind what's unique about pediatric HIV infection in doing these very early treatment strategies. And early treatment strategies where we can begin to think about immunotherapeutics is that we generally know by testing pregnant people their status. And so infants can get infected during pregnancy, during labor delivery, and ongoing exposure with breastfeeding. And so our target here was very early treatment of infants who acquired infection in utero. And we can tell that because we have a testing algorithm. If you have HIV nucleic acid present on blood samples, and it has to be 2 blood samples collected on 2 different times, that signals in the first 48 hours of life, that signals in utero infection. And so now I'm going to switch gear to the clinical trials, and this is version 1 of the trial, which started in 2015. We're now in version 3 of the trial that has advanced to include integrase inhibitors plus broadly neutralizing antibodies with BR07-523LS. But just to say, when I present these data, when this study started, and you could see the drug regimen in the bottom, all we had available to think about using for this remission outcome is zidovudine, lamivudine, nevirapine. A dose was not established, and lopinavir-ritonavir. Lopinavir-ritonavir is the drug that until we have dolutegravir rollout, the drug that's used globally to treat perinatal HIV infection. Nevirapine, as I said, there was no dosing. So we started with AZT3TC nevirapine. Lopinavir-ritonavir cannot be given until a certain age, post-gestational age of 42 weeks, because of the high alcohol content. So we added lopinavir-ritonavir when age appropriate, so these infants got a 4-drug regimen. So essentially it was preemptive treatment of this cohort 1 group. So 440 mother-infant pairs were enrolled in step 1, and you could see here this represents, these are trials at sites where the burden of infection is. So in terms of implementation of this, we have established feasibility in doing this in a global way. So in 11 countries in South America, in South Africa, and also in Thailand. So infants were enrolled in cohort 1 prospectively, not knowing their infection status, but their moms were diagnosed during labor and delivery. So these were mothers who did not know their infection status. The transmission rate is somewhere about 6 to 8%. So as I said, we powered the study to detect 1 case of remission. Cohort 2, we decided to have an opportunistic enrollment for pediatricians who may start their kids on triple ARV prophylaxis, as in the Mississippi Baby, which became an uptake in many countries around the world and also within the US, to have these kids enter into the trial around 8 days of age. And so what we ended up with in terms of the amount of participants who had confirmed infection from these 440, we had 34 in cohort 1 and 20 in cohort 2. So we ended up with 54 evaluable infants to continue on the study treatment of zidovudine, lamivudine, nevirapine with lopinavir-ritonavir, added when age appropriate. And then we de-escalated the regimen to a lopinavir-based ART regimen when virologic suppression was achieved on 2 consecutive time points in the first year of life. And so the eligibility for step 3 was maintaining virologic suppression. And so I kind of want to quickly go over these numbers here. The main thing is really to see the age of triple ARV initiation. So it was about 7 hours of life in cohort 1 and 33 hours of life in cohort 2. We did identify in this prospective cohort, this observation by Philip Golder's group, that girls are more susceptible to in utero infection than boys. And so we did see that in that cohort 1, and something Sumia Becca, a PhD student in my lab, is investigating. Most of these are breastfed infants. The cohort 2 differed because moms could have been on ARVs, but not suppressed. I just want to say these infants were followed very closely for viral load monitoring. So each of these represent the study visits and the time points at which we collected cells to quantify HIV DNA with a single plex DNA PCR that just estimates the total number of HIV infected cells, antibody testing, immune testing with CD4, and of course, safety monitoring, because there is no safety profile of these drugs. And I'm going to quickly go through our virologic suppression criteria to remain on study. And, this was our first foray into this, and this is 2015. So we're almost a decade later into this. And we wanted to make sure we kept the best of the best in this trial to undergo therapy, because we wanted to have the success of an N of 1. And so we had these criteria in terms of the infants had to achieve under less than 200 copies per mil by week 24. And then by week 48 onwards, to stay on the study, I had to have absolutely no HIV RNA detected, including at the level of target not detected, to enter into this eligibility for ART interruption. And I'm going to go through the eligibility criteria with you. And that was to start at around 2 years of age. And so the pre-ATI criteria was really based on what I said before, reaching less than 200, having sustained undetectable viremia from 48 weeks onwards. They have to have stopped breastfeeding by at least 6 weeks. And of course, the parent or guardian had to agree to, consent to enter ATI, right? Because this is stopping drugs in children and monitoring them to see if the virus would come back. And then we had a predefined biomarker profile to stop therapy, which is not done in the adult settings. It's you get your intervention, and then at some period, ART stopped and participants are followed for rebound. But we knew from early treated children that you could get to about 50% around 5 to 6 years of age if they maintain suppression, could get to this profile of low DNA and absent or near absent antibody responses. And so we sort of built that biomarker profile as an indicator of low reservoir cells, so low virus expression cells. And so these children had to have that by age 2. When we started the eligibility criteria on 2 separate samples, we had to make sure we tested enough PBMC so we're not overestimating non-detectable HIV DNA state. And it had to be in a CLIA certified lab. So we have a CLIA certified pan subtype single plex droplet digital PCR assay that we use to test these infants, because you're taking them off therapy. So it has to be a CLIA certified assay. We are the testing lab for the cabotegravir PrEP study. And I should have included those data. We're very, cabotegravir, long-acting cabotegravir, and Sue Elshman reported on this, can actually abort HIV infection sufficiently in adults that we need the DNA test to actually detect infection. And so this is the assay that's also used in that trial. We also offer that testing. Sometimes physicians get they're not sure if a patient's infected or not because of the discrepancies in the testing, and we do provide that as a clinical test in this lab. And ART-free remission, we defined as having sustained aviremia off ART for 48 or more weeks, as I said before. So as I present the remission data, I want to kind of show you, so this is, keep in mind, these are infants with in utero infection. We don't know how to time when that occurs. The timeline for that is shifting somewhere in the last trimester, but most have refined it based on our prevention trials to the last 6 weeks of pregnancy. Although, David and I were discussing, we've had preterm infants as young as 25 weeks being born with infection. So it's happening in the last trimester. But what you see here is really at week 24, the proportion of infants who got to less than 200 So to stay on trial, so 24 in cohort 1 and 15 of 20 in cohort 2. And these infants showing classic biphasic decay in plasma viral load, initial rapid phase decay, reflective of clearance of infection in activated CD4 cells, and then slow decline in other long-lived cellular populations. So confirming established infection in these infants. And what you see here is in the cohort 1, which is prospective before therapy started, the median viral load is about 5 logs. But you could see some infants have up to 6 logs, so 1 million copies per mil. So HIV really being able to replicate in fetal cells in this trial. And I think that's what this trial has really been able to unravel for us, because we have never really studied systematically in utero infection in children. And cohort 2, obviously they came into the trial around a median of day 8 days of age, so their viral loads were still high, about 4.1 on the ART regimen. So just to kind of quickly summarize where we are with less virologic suppression in these infants, by week 24, a set of twins pulled out, withdrew from the study. They didn't want to participate anymore, so we ended up with 32. And so the suppression rates were some 75% and 88% in cohort 1 and 2, with 53% really getting to the level of no target detected, and 47% in cohort 2. Now, I do want to say, that the plasma viral load kinetics were similar to what we see with standard early ART in children at 2 to 3 months of age, and in adults and adolescents starting therapy with 2 to 3 logs by 8 weeks of therapy. As I said, we were very excited with this high rate of suppression, because about 44% of kids are not suppressed on therapy, and some kids take very long to become undetectable if they start out with a very high infected cell burden. But as the trial went on to 2 years of age, a lot of children lost virologic suppression. And so in cohort 1, with this AZT3TC nevirapine Kaletra-based regimen that was de-escalated to Kaletra, and most stopped the nevirapine at around 7 to 8 months of age in both cohorts, 33% maintained virologic suppression, so didn't experience virologic failure in cohort 1, and 57% in cohort 2. I will say cohort 2 is sort of skewed. I mean, these were infants whose moms had established infection, and a high proportion were from Uganda with subtype AD infection. There's some data to suggest that AD in adult space, we were now studying that in a pediatric space, that the immunopathogenesis of reservoirs might be different. And Tom Quinn has done a lot of work in this space. And just to show you, when plasma viral loads get to undetectable, it's very hard to monitor what's happening in the infection status. So DNA is a great biomarker to measure what's happening over the time course of treatment. And what you could see at 24 weeks, even though these infants are getting to undetectable or near undetectable to less than 200, and even those that are getting to target not detected, there are still a lot of cells with HIV DNA in here in the first 6 months of life. Obviously, these are cells, we're only measuring total DNA, not intact DNA. As Bob's pioneered the intact proviral DNA assay that's really showing high proportion of defectives. So me, Becca, in my lab, we've just started to do proviral landscape analysis showing about 50% of the genomes in these kids are actually intact. We don't know the integration profile because they're pre-therapy levels, but we're getting to the point of having at least a subtype C IPD up and running in the lab, and hopefully a pan subtype in collaboration with a cellular diagnostics. And so I'm just going to say through 2 years of age, you could see we lost a lot of kids due to virologic failure, but the HIV DNA levels decreased in some. Even one infant who had non-detectable, shown in red DNA, during actually a lot of the time points studied, had some detectable level, exited the study, so we couldn't really tell whether this kid actually would have achieved remission. So we lost one child because of family and disclosure issues. But nevertheless, you could see that we had some children who started out during the trial with no detectable DNA. There were 4 of them, 3 in cohort 1, 1 in cohort 2, with non-detectable DNA that we think represents more recent infection. So I'm going to go, I think just to kind of bring some, we're nowhere near statistical significance with these findings, but because we have a version 2 that's now fully enrolled with 22 infants who got a raltegravir-based regimen, and some got VRC01, a broadly neutralizing CD4 blocking broadly neutralizing antibody, we can begin to explore these potential predictors of strict virologic control. That's not necessarily just an issue of the drug regimen that's being used. And here again, we found this at male sex. Boys were more likely to maintain strict virologic control compared with girls through the first 2 years of age. And when we went and looked back, boys had lower plasma viral load in this prospective cohort and lower DNA levels. So something we need to really now pay attention to sex differences in cure interventions in perinatal HIV infection, but we'll be able to refine this more because we have more participants involved. And then in both cohorts, the initial plasma viral loads seem to suggest a breakpoint at around 10,000 versus greater than 10,000. Suggested that we may be able to identify additional biomarkers that lead to virologic control other than adherence issues and drug regimens. This was a first proof of concept study of very early treatment. So we're giving neonates a 3-drug regimen, and only those who got confirmed infection received the Kaletra component. But, if we think back of the numbers, we had 440 infants in that prospective cohort and 20 in the other. Of the 440, only 34 were infected. So we're giving 400 infants who didn't end up being infected a 3-drug regimen. So it's important to closely monitor the safety profile. And in the first 6 months of life, we saw a high level of grade 3-4 adverse events. All were reversible. There were neutropenia and anemia, which is known to occur with zidovudine. With switch to abacavir, we were able to, it quickly reverts. Most settings, as part of standard of care, the white cell counts are not monitored. So these were not clinically, there was no clinical manifestation. We just identified this. And then lopinavir is known to give precocious puberty. And so we had one infant of the 54 who experienced this. And 2 deaths occurred. One was, both were not related to the study regimen, but really highlighting we still have mortality with very early treatment, and then tragic cases of a case of poisoning in an 80-week-old infant. Okay, so what we ended up with by age 2 years, of the 54, we ended up with 10. So nearly 20% of the cohort met all criteria for possible analytic treatment interruption that we couldn't do because of COVID. So we went from 10. I just kind of wanted to give this timeline. Managing these studies are very, very complicated and having to do a lot of amendments over the course. So what you see here is the enrollment and consideration. May 2020, we had to pause the study because of COVID, so we couldn't do the ATI. And so it wasn't until 2 years later, May 2022, they were able to do the first ATI. You just have to think about these mother-infant pairs or guardian children pairs coming, some come from very far. We provide transportation and food. Some have food insecurity. Real commitment of our study. We lose very few participants in our study to loss to follow-up. So in any event, I just wanted to kind of, when we present these data for the group to recognize how challenging these studies are in all of our settings in the US and in resource-constrained settings. One other aspect of this, we measured lopinavir concentrations. It's really such a bad, it's taken us through improving life survival in children, so I shouldn't say it's a bad drug, but it really tastes poorly. It's hard for parents to travel with, so disclosure of status becomes a problem. So staying adherent is really hard. And so 38% of our samples that we tested in the first 2 years didn't have any detectable level, really testing random samples. But of those who achieved concentrations, they were in the range that we typically see in adults, in the therapeutic range. So I think a good sign. So here we are, 6 children in 2022, 6 children met criteria to stop therapy. I just want to remind the group, the reason we're stopping therapy is in 2024, as of now. We have no biomarker known to be predictive of art-free remission. So the only way to do this is to stop therapy and monitor closely. And how often do you monitor is really hard. How do you set those intervals of testing? Very, very hard. And it comes with a lot of anxieties when the participants are coming to clinic. Is today going to be the day that I rebound? We really need a home test to be able to do this better. In any event, the median age of stopping art instead of 2 was about 5.5 years. It's important to point out that time difference because our initial clinical trials endpoint was to stop at around 2 to 3 years of age. We know the natural history of HIV infection, perinatal infection, untreated infection. 50% of kids die at by 2 years of age. And then a few of the 50% that survive beyond age 2. Around age 5 is when the viral load set point occurs. So the set point is very different as in adults. Within a few weeks to months, you see your viral load set point that's predictive of disease progression. In children, it takes about 5 years for that CTL response to kick in to get to your set point. So we don't know to what extent stopping at 5.5 years influenced our trial's outcome versus 2 years, but obviously we have archived samples that we can begin to look at immune response profiling during this period. I went through these before, but just to remind you, we had preset criteria for those who could undergo treatment and ATI. And so we had the 6 kids who underwent therapy. And then once you get here, you have to do all this monitoring to be sure that your ATI is going to be safe and that you can detect virologic rebound. And this became actually important in terms of, as I'll discuss later, but the RNA testing, we used an on-demand, the CFAR, that was a 90-minute turnaround while the family stayed in the clinic to make sure there was no rebound. Any rebound by CFAR, detected by CFAR, is confirmed by the standard Roche or Abbott viral load assay with 20 and 40 copy limit of detection, and then obviously immunologic monitoring. So these are our 6 participants, A through F, the 2 hashed. We had 2 children who, despite going through this very early treatment, getting to all our biomarkers, who rebounded. So participants E and F at 3 and 8 weeks, and I'll show the rebound profile. So what you can see is 4 were from Uganda, where subtype AD predominates, and we had 2 subtype C, Tanzania and Zimbabwe. We had 4 girls and 2 boys, and this has relevance because, as I'll close with, there's a South African study by Philip Goulder's group presented at CROI, who's also part of the PAVE collaboratory. He identified 5 boys who achieved remission, not in a structured treatment interruption way as we did, but who went off therapy that didn't rebound, that they're following closely. So we were happy that there were girls. In fact, 4 were girls and 2 were boys. You could see, and I think Joel's on. So we, obviously HLA in an adult is predictive of elite controller status. In African populations, these are the HLA alleles associated with being protective, as shown in green. So 27, 5801 and 88, 8101. And then they're disease susceptible alleles. So we have, analyzed our 54, actually 52, because in 2 of them, the parents didn't agree to do genetic testing. And so we have now a biobank of overall prevalence of these alleles in our populations that we're studying, that we can begin to explore to what extent these alleles contribute to virologic suppression, not just remission, but in that composite profile in terms of viral load. And as I said, age at ATI was about 5.5 years of age. So this is showing the sustained viremia. So as I said, 48 weeks or more is what we considered success. So 4 of the 6 participants, A, B, C, and D, reached the 48-week mark. Participant A went the farthest out at 80 weeks before rebounding. And so we estimated with this sort of treatment profile and then biomarker profile, 67% of those becoming eligible for remission actually achieve remission, which is not bad. It's actually more than we anticipated, so we're very excited about this. These are the rebound kinetics in the 2 who rebounded early. So these 2 were identified during our routine testing because we had weekly testing in the first 4 weeks, and then every 2 weeks in the next 8 weeks. And so E and F were detected during a routine screening at 3 and 8 weeks. Participant E, and actually I should remember, it's E, it developed acute retroviral syndrome after we detected a day after we detected the viremic rebound, developed a sore throat and a little bit of fever that was really discounted by the family. But when we went back and asked critically, because participant A, as I will show you, developed more extended symptoms of acute retroviral syndrome. We very rarely see acute retroviral syndrome in the pediatric population. So this was surprising to us, and we had to modify our protocol based on that. But what you see is the duration of ART at the time of presentation at CROI, where it was 48 weeks or more. So from 48 weeks to 80 weeks in these 4 participants. So definitely ART-free remission. I want to say that these kids had bona fide established infection. Participant A, who went for 80 weeks, had a viral load of 5 million copies on day 0 of life. So clearly had infection, and these are the time frames to a target not detected for viral load. So some taking up to 17 weeks to get there, and then 9 or 10 weeks. Obviously, this time frame is based on how frequently we monitor them during the first 6 months of life. And you could see, all of them had detectable viremia with participant E, with a lower level of viremia detected at 8 days of age, and the same for D. Obviously, trying to figure out, is there I don't want to say a reservoir, is there a pool of infected cells that we could readily identify in the first few days of life? And you could see 4 of 6. So 2 of the 4 who didn't have detectable DNA made it through the study to the remission endpoint. I think it's an important, we need to kind of unravel that, but 4 of 6 had clear detectable DNA here, confirming infection, at least longer lived cells that we could detect through 9 days of life. And here we show the earliest age. And so, curious, and we don't want to make any observation on N of 6 and N of 2, but the 2 who rebounded early took longer to get to that not detected DNA level. So something we're going to have to sort of decipher as we march through the other versions of the trial. So I do want to come back to participant A, who went for 80 weeks, really 80 weeks with nothing, developed a fever and a headache that the mom just thought was a mild URI and didn't think anything of it, but you could see this progressed to a rash and tonsillitis, etc. These were all mild clinical symptoms, except for the neutropenia, which occurred later, and then when drugs were restarted too. But this child became resuppressed by 7 weeks of age. I think all 3 kids, I know all 3 kids became suppressed on the regimen they were on. We get asked to these kids, is there concern for resistance during the ART interruption stage? Because it's happening so much later, we're not concerned about it, but they all resuppressed on the regimen, confirming that they still had drug susceptible virus. This is the second participant E at 8 weeks. Yeah, acute retroviral syndrome, again, mild symptoms. Resuppression took 20 weeks in this child due to non-adherence, not due to resistance, we don't think. And then this other participant became suppressed, was completely asymptomatic during viral rebound, became suppressed by 8 weeks. Obviously, we wanted, before we even reported this, we wanted to be sure that the parents had really stopped the antiretroviral drugs. And so you could see pre-ATI, there were lopinavir is what we measured, readily detectable. We even measured for dolutegravir. It's not shown here to be sure they weren't getting some other combination. We didn't detect dolutegravir. And so this confirmed that there really was an ATI and our discontinuation, that we could feel confident that this is remission indeed. So you could see none of the samples tested in all of the 6 participants had detectable lopinavir. And so combined, we think this is what remission looks like in perinatal infection or any adult infection, really, is that you can confirm that there's delayed rebound for whatever time frame you set. I think 48 weeks to have a kid go off therapy for a year is a reasonable, I feel like that's a reasonable time frame for any remission trial, and that's probably going to be our benchmark going forward. But we think combined with not being able to detect drug and having sustained aviremia, not the typical 2 to 4 weeks, as we're saying in participant E and F, but delayed suppression of rebound, remission for sure. And so to kind of summarize here, I think we've now provided 9 years later proof of concept at very early art of neonates with in utero HIV significantly control the reservoirs, because these infants had to test antibody negative to go through the ATI step. And so that suggests that they have very little antigenic exposure to elicit an immune response. And we don't think they would have any CTL responses that would confer this sort of remission outcome. Trying to establish a biomarker profile so we can avoid ATI is central and pivotal for the field. We thought we did not too badly, but we weren't perfect, because 4 of 6 who met those criteria actually achieved remission. But then we had 2 that it was completely not predictive of. So we need to kind of figure out what that biomarker profile should look like. And it turns out the Gates Foundation has invested a lot in biomarker discovery. And so we're partnering with them to sort of use these samples to piggyback on the adult biomarker profiling to be able to inform our studies so we don't have to stop therapy in children. And obviously the occurrence of acute retroviral syndrome was sobering in us, to the point that we actually completely modified the protocol now for version 3, where any fever, sore throat, they're going to have an on-demand viral load test so we can reinitiate therapy as soon as possible and diagnose rebound. I go through the study limitations. I think as you think about this, your adults are so used to having access to really potent regimen, combination regimens, single pill, single injection regimens, and we're not there yet in pediatrics. And so we're what this is with AZT3/TC, nevirapine, and Kaletra. Obviously, version 2, we have a raltegravir-based regimen with VRC01 that's completed now, and those infants are going to go march through the 2-year time point for ATI following the same biomarker profile. And now for version 3, as I said, we will switch to dolutegravir because that's being rolled out globally. We want to stay up with what's being available in countries so that these findings can be rapidly implemented in resource-constrained settings. And I'm very excited about this part. We've actually now started conversations with PEPFAR to how to get near point of care testing at our countries, where, at least to start out, where PEPFAR is and where the clinical trial sites overlap, to be able to see how this can be implemented in a more reasonable manner. So I kind of want to end with this kind of HIV cure landscape. As most of you know, the discovery of the latent reservoir here in 1997. Joe Blanks has shown this even in elite controllers. They have it. They just can control it. I think the elite controller model remains the model that we should think about. We don't want to follow kids and wait for rebound. We want to get them to reduce reservoirs and figure out how to control rebound. So that's where we need to start thinking. We had to show proof of concept that the very early treatment would work. And so we did. We anticipated 1 case. We have 4 cases. The Berlin patient here, and now where we are is, as all of you know, in the adult space, you have 4 additional cures with stem cell transplantation with CCR5 delta 32, including our one we're very proud of, the New York woman, because she's a woman. So of all of these are men. She's a woman of mixed race who got a cord blood that afforded her cure of her AML and remission of her HIV. And actually, she's now over 3 years with sustained aviremia, so we'll probably write her up as a cured case. And then the 2 cases of the 2 women elite controllers who have absolutely a real paucity of intact proviruses on sampling of billion cells that Matthias Lichterfeld does for the field through elite controllers. So showing that with immune effector responses, you could eliminate, well, we don't really know whether these 2, the Esperanza patient and the San Francisco woman, whether they started out this way or whether, and maybe Joel can comment on this, or whether this was, loss of intact proviruses over their time course through their immune-mediated responses. But I think this is going to be key to remission for children and adults, is to have some immune therapies to control. And we're now, let me just kind of go to the Mississippi. So we had the Mississippi baby in 2013, and then 2 perinatal infections treated early, 2 to 3 months of age, were identified in early pre-adolescent stages, and both of these with 12 or more years of virologic suppression of ART. These 2 cases differ from the Mississippi baby in that you could readily detect DNA in them. You can actually detect the induced RNA, so there must be some immune effector mechanism, or also a lot of defectives that are present. And the South African boy is really being studied in detail as part of the PAVE collaboratory. He seems to have very low levels of CCR5 expression and a low immune activation profiling. So these single cases can teach us a lot. And then we're really proud in 2024, so 11 years later, we have our 4 cases of remission. And now the 5 South African males, this is a protocol that is exactly what P1115 did. Philip Goulder's group in South Africa, and Roger Shapiro in Botswana took the P1115 protocol and tried to implement it at a single site level. And Philip and his cohort of 340 plus children have identified these 5 South African males. Again, I said they went off therapy and they couldn't measure drugs, and so they're calling them remission cases, but I think they're now systematically going to follow them to look for remission. So we could say we now have 9 cases of remission from very early treatment. What Roger Shapiro's done in his group, because the Botswana IRB did not approve ATI in his study of very early treatment, he's shown that if you give 2 bNAbs, monthly infusions of 2 bNAbs, 44% of the, and I should remember the number, 44% of, there were 11 of them that equaled 44%. I can't do my math, but 44% achieved sustained virologic suppression for 24 weeks on a treatment switch from standard ART to monthly infusions of a bNAb. And the correlate of that was actually having that biomarker profile of being DNA negative and antibody negative, or low DNA levels. So I think we're coming up through these multiple studies with a framework for thinking about very early treatment, bNAbs, long-acting, etc., to achieve more remission in cases. So I just kind of want to quickly go through that. We didn't stop at version 1. Version 2 have enrolled 430 mother-infant pairs, and we now have 22 infants that got raltegravir instead of lopinavir, ritonavir with the VRC01. And version 3 is about to open, in which we will enroll 230 mother-infant pairs. Going forward in a version 3, what we want to do is not have to enroll all of these infants, is really to have point-of-care testing so that within 48 hours we can stop the regimens and just only treat who those are infected. So why is this important? I need to bring this back because people think pediatric HIV is disappearing. It's not disappearing, it's plateaued. We have 130,000 new infections in children. There are 1.5 million living with HIV under 15, nearly 3 million under 19 living with HIV. So we need, and therapy is lifelong. An early treated kid can live 30 to 40 years, and Allison and David take care of these kids. So a lot to do in this space, and we need to, but we do believe that we've now demonstrated that ART-free remission is possible in perinatal infection, and that this agenda is really giving a strong pipeline of therapies for children born or living with HIV, and even young adults living with perinatal HIV. I kind of want to bring back this point, and I really should have, I apologize, put in a slide on this, is the Levi syndrome, and I'm forgetting, maybe someone remembers what it stands for, the long early viral infection or something, syndrome occurring after cabotegravir PrEP, reported out from HPTN 084 of adults who get infected while on cabotegravir that are able to have such exceedingly low viral reservoirs. And so I see Yuka has her hand up, but I'm going to stop by ending by saying that I think our partnership, now that we've started with PEPFAR, our partnership with Gates, I didn't have time to present, I didn't include it here, our PAVE Martin Delaney Collaboratory, we find in a preclinical infant model, AAV vector delivery of 2 bNAbs. So you give a single shot, start ART, we're able to have sustained suppression in that NHP model off ART with a 2 bNAb combination. So we're trying to figure out how to move gene delivery of body neutralizing antibodies to kids in sub-Saharan Africa, because adherence is a problem, stigma is a problem. Breastfeeding, kids could escape infection in utero and peripartum, but they're still at risk. 18 months of breastfeeding is what's generally done in the population we serve. And then kids become sexually active, sexual debuts around 12 years of age, 12 to 14. And so if we can figure out ways to cure and prevent with the same strategies of long-acting deliverables, we do believe in the next 10 years, we could really get to near elimination of pediatric HIV infection. It's ambitious, but I do want to stop on that note. And I'll take questions. Oh, wait, I have to acknowledge that study teams, done in a lot of countries, a lot of people, a village really involved. And this was our group at CROI when this was presented. Everyone was excited about the finding. And obviously the impact network that supports the study that's funded by NIAID, NICHD, and NIMH, and are the people in my lab who do the testing here for the HIV DNA. And I'll stop there.
Well, Debbie, that was amazing. Luca, you had your hand up so politely, so go ahead.
Yeah, I just had a quick question, Debbie, fantastic talk, about the initial viral load after that you confirmed in utero infection. So it looks like the ones that were most likely to suppress were ones that were low at the beginning. So does that have something to do with the timing of when they got infected in utero, do you think? Or does it matter? And then the second question I had for you is why so few people why the proportion is so low that suppress? Is that just an adherence issue, or is there some other biologic reason that I just don't know about?
Yeah, no, those are really good questions. So the first, in terms of the low viral load, right? What does that mean? Is it
the initial low viral load?
Right. Is it just timing of infection? And this is something that we're exploring in this lab. So I think it's actually multifactorial, Yuka, because we don't have a way. And I wish we could, we're trying to establish like a molecular clock approach to sort of establish timing of in utero infection. I think it's easy to say it's, recent infection. I think the DNA tells us something in terms of recent infection, perhaps in terms of timing for those cells to proliferate or get new infection events. I think it's multifactorial. So what it could be the replication capacity of the virus. And so we have now systems in place to be able to do that simultaneously. Philip Goulder has shown this interaction. I mentioned that girls are more susceptible to infection than boys in utero. And it's not that girls are more likely to survive in utero infection, because he's gone back to biobanks and twin studies and confirmed that girls are more susceptible to in utero infection. And that susceptibility seems to be linked to interferon resistance. So, and this is a single site study. This is the story that he's put forward. And because we now found that more girls were infected in our prospective cohort, we can now systematically go back and measure interferon resistance. And this is part of Samia Becca's PhD thesis project to understand exactly what you're saying, Yuka, what's driving that viral load, because we did see 10,000 as a signal. So how do we get to that 10,000 as a biomarker of lower risk of virologic failure? So what he found, girls are more likely to be infected and they have interferon resistant virus. But that interferon resistant virus is linked to low replication capacity. So it's a story that we need to kind of unravel. And then the other thing is, this is infection in the context of a mother-infant diet pair, and the infant shares alleles, HLA alleles with the mom. We don't know to what extent HLA alleles play a part. The other thing is that moms transfer IgG across the placenta. So there may be immune effector mechanisms that, it's probably a very complex story. But I think we'll be able to unravel that from these clinical trials where, the next part of my talk, we don't just do these clinical trials outcome, we do laboratory science in trying to understand the immunopathogenesis by looking at the proviral landscape. And so, to what extent will we identifying these kids? They have a very complex proviral landscape as seen in adults with intacts and defectives and hypermutated. So a lot to kind of figure out, Yuka. So that was your first question. Then I forgot. Oh, your second question was why so much failure, right? So yesterday when I presented this talk, Bob asked me the same question, and my simple answer was non-adherence, poor drug access to, stable access to drugs. That's a simple answer, but I don't think it's the full story. I think and we kind of have to unravel this. Some kids are starting out with infected cell concentrations that are 10,000 copies per million PBMCs, not even CD4. If we enrich that for CD4, it would be 30,000 or 40,000. And some kids are starting out with 2 copies and 3 copies. So we need to kind of understand that. We just did some pilot integration site profiling to see to what extent, because we hypothesized that perhaps the reason these kids are getting to remission is that clonal expansion, as you see in adults, and then I'm sure you guys saw Bob's study recently, 20 years, the reservoir is actually expanding, it's not contracting. In children, it's very different, it contracts. Like we're very excited, our 20-year-olds, in well-suppressed 20-year-olds have less than 1 intact in 1 billion cells. So we're, with early 20 years of treatment, we're getting to a different space than adults where your reservoir is expanding. And now I lost track. Oh, your second question had to do, the failure. And so I think it could be multifactorial. First of all, lopinavir is really bad tasting. The concentrations vary a lot. You need food to take with that. A lot of our participants have food insecurities. I mean, we provide meals. We try to make this as holistic as we can in reality. And so I think a lot of it is drugs. And as I said, I like this term that I never thought about that Charlie Flexner said at CROI, that people don't fail drugs, drugs fail people. And I think in the pediatric space, we're failing because we don't have really good, potent, and once-a-day regimens right now for that very vulnerable age group. And so, but we're getting there. Like dolutegravir now can be used. And David gave a nice overview today at our conference. It can be used from 4 weeks onwards. With scored tablets, a combination. And so the Impact Network, we will have dolutegravir dosing in the first 4 weeks of life. We're working on dosing of lenacapavir on long-acting for a pediatric cohort, so we can do better with adherence. But I think that we need to understand intact proviral load and it's as a correlate of suppression. And I strongly believe if we can give immunotherapeutics, broadly neutralizing antibody that could sop up those viruses as they come out of cells to get our kids to undetectable faster and have lower viral loads, I think we will have I want to go from 54 to 40 and then to near 90%. And I think we can get there. And the other thing is we did identify that some of these neonates have clonal expansion. So in utero, these cells are clonally expanding. And whether HIV is driving that clonal expansion or whether it's just antigenic exposure, whether it's where it's integrated or antigenic exposure to the virus that's actually driving that clonal proliferation, we will be able to answer that with our cohorts. And so I hope I answered your question in like 20 sentences.
Yes, it's excellent. There's not enough time. Thanks you so much. It was so good.
Yeah, Debbie, this was amazing. And I have like a million questions too, but since we're already after 1 o'clock, I will hold them for another time because I just think this is such a fascinating and important area where there's just been so much progress in the last few years. It's a really exciting space. And so I will just say thank you for your leadership in this area, for all the work you've done and for coming to share this with us today. There's lots of people saying thank you in the chat.
Yeah, no, it's great. Thank you for giving me this opportunity, Eileen and Richard. Yep. Bye-bye.
All right. Have a wonderful weekend, everyone. Oh, and Joel said it was fantastic.